So that's going to move us into our next little topic, and I think it's musculoskeletal, right? Okay, this one, I know that I often offer this, what we may do, because I have talked about a lot of the conditions like your verum and your dysplasia and all, hip dysplasia, I may allow you to look at that section because I don't want to have to repeat something that we've already had and get you too exhausted, but we'll see what we want to think about. It's pretty easy to move through. But I want you to think about, we're going to start off with some inflammatory disorders, and then let me tell you what's big on the test. Kids with a limping kids, okay? That's a pink pig. So we want to think about inflammatory disorder. Good old Osgood-Schlatter would be one that's very classic, and toxic synovitis, which is also considered in the limp disorders. So let's talk about Osgood-Schlatter. I love that term. Sounds like a sandwich, doesn't it? Osgood-Schlatter, like a German sandwich or something. But if the tibial tubercle becomes prominent because of repetitive stress during the time that the child is what? Going through their growth spurt, repetitive motion. And so what we think about is right down here with the tibial tubercle, pain, tenderness of the tibial tubercle, point tenderness, and enlargement, especially on the affected side compared to the unaffected side. A lot of kids that I've had have had it bilaterally, but you may find that this is just on one leg. These are kids that play, basketball or doing track or whatever. They're putting this repetitive stress on that extremity. So really, x-rays could, really rule out more serious causes, but you want to think about perhaps putting them in some type of a splint for the knee. You don't need to tell them they can't play their sport. They will limit their involvement in the sport till they feel better. And mainly just give them some support during that time frame. Now, once the pain goes away, that tibial tubercle that has been pulled out, because isn't it like an avulsion injury? It's like where the insertion of the soft tissue joint connection is, it pulls that bone outward and makes it prominent. It will always be present. Here's toxic synovitis, inflammation of the hip, viral immune causes, 2 to 6 years of age. We think about kids that have that painful limp, but when you look at the hip, it's really not showing any signs of infection. But when you examine, say you take that hip and you rotate the leg, you'll probably get them into some type of a spasm because it's very painful. The only thing we're going to think about is if the child has no fever, you don't need to hospitalize them, but if they have fever, what would be in your differential? Probably arthritis, septic arthritis. And that's a child that would need to go on and be hospitalized. You could do some joint fluid aspirations, but if you did it, it's going to be normal, usually. So a lot of times we will just let it run its course. X-rays will be normal, bed rest. Pretty much just, think about watching and see if they develop a fever and whether or not they need to be hospitalized. Good old analgesics and bed rest. So that brings us into limping disorders. And the two, I'm going to actually go over in detail leg calvi-perthus disease and slip capital femoral epiphysis. But I want to tell you that we already did toxic synovitis. We don't cover juvenile and septic arthritis, but the septic arthritis, mainly it's the fever that would be associated with it. So let's talk about the first one, leg calvi-perthus disease. This is an interesting one. It's an aseptic avascular necrosis of the femoral head. So that means that in a child, we really don't know what's causing it, but it does have some vascular disruption, and the child may appear shorter in stature and compared to their peers. Usually it's young children, say 4 to 8, somewhere in that range. We also think about, this is a child that starts to limp, and it's an insidious limp with knee pain. Now, I want to make sure you all take a very special note. I know people are getting tired because we've spent a lot of time together, but highlight this. Highlight what direction the pain occurs. The pain is in the knee, and it migrates up the thigh into the groin and the lateral hip. So does that make sense to you? It goes from the knee up the thigh and out towards the groin. That's going to be important because the next one I talk about, slipped capital femoral epiphysis, goes in the opposite direction. And that will help you on a test question. We also think about pain as less acute, severe than transient synovitis, septic arthritis, and they are afebrile. You want to think about, too, what kind of range of motion do you have? Well, it's probably going to be passive internal rotation, especially when you abduct the hip joint. And they may even be resisted by some mild spasming. Hip flexion, contracture, and leg muscles may atrophy in long-term periods of time when the child has this. I've had people who have told me in this class that they've had it, and I've also had patients that have had it. You can have it for a year to 2 to maybe 3 years. You can have this condition. Doesn't mean that it needs to be, we can do x-rays. There's no other laboratory tests, so we want to know how we're going to treat it. Treatment goal is to restore range of motion, maintain that femoral head attached to the acetabulum. Really, we will just do observation if their full range of motion is preserved. They're younger, say under 6, and less than half of the femoral head is involved. How are you going to know that? You did an x-ray, right? So that means that that's a less fragile hip, so you're just going to observe them. If the child is more than half the femoral head is involved and they're older than 6, you need to refer them over to orthopedics because it's probably much more fragile, much more at risk for damage. Now here is slipped capital femoral epiphysis skiffy. Spontaneous dislocation femoral head, downward, backward. You know what it reminds me of? Hip dysplasia in an older child. Femoral neck is secondary to the disruption of the epiphyseal plate. Pretty much we don't really know what causes it, but it has been known to be seen in children that are older, when they've typically, during their growth spurt and prior to menarche in females, children that are more sedentary and more overweight. Typically you will see this occur. The pain, this is what you need to start or put next to it. The pain is in the groin, and it goes down the thigh to the knee. So that's really key. So when you get a test question with one of these, knowing which direction the pain will really help you. When there's acute onset pain will be severe. Physical findings, they cannot flex their hip, abduct, or rotate externally. You may even observe limb shortening, or what we call leg length discrepancy. And what you're going to think about is typically doing x-rays certainly will be helpful. And how are you going to treat this kid? This is much more serious. These are kids that need to immediately be referred to orthopedists because often they need to be immediately off, no ambulation, not being able to ambulate or walk because you're concerned that you're going to disrupt that joint to the point that it's going to be very difficult to repair. These individuals will need to they'll probably go to surgery. They often will pin fixate that joint to give it support, and you have to watch the other hip for the same. Often it's unilateral, but can become a secondary. The other hip can be involved. So if I had to leave you with something on limping, they like to ask you questions about either skiffy or leg cavity perthes disease. And we kind of distinguished them, right? You saw one was worse than the other and what direction the pain goes in, typically doing x-rays. Now we've got structural disorders. We've got the good old Genu, Valgum, scoliosis, and hip dysplasia. There's a good picture of Valgum. Bow-leggedness, normal variant up to 2. And it basically does mean that the child can retain their full range of motion. And when you think about there's really nothing to do under the age of 2, you only need to refer if it continues after 2, is unilateral, and becomes worse. You know, as kids, toddlers, 2-year-olds, as they get more active, they're going to outgrow that. Now, we think about Valgum knock knees. Up to 7, it's normal. Preschoolers. And if you'll just look right here, these are what's called the medial malleoli, the bony prominences in the inner medial ankle. They're going to have a pretty wide space there, which means it's more than 3 inches. There's no pain, full range of motion. They can walk and run. Typically, they outgrow that. Nothing is necessary. X-rays only if age 7 or unilateral involvement. Then you might want to see what else might be going on with that. Typically, older children need further evaluation, but most of the time they're going to outgrow that. Now here's scoliosis, the lateral curvature of the spine. Most common in adolescents. You've heard of what's called idiopathic scoliosis. Females, family history, that's real common. Now we have other types of scoliosis. Don't we have what's called the congenital, which remember we did the assessment today with the newborn, you could see a lateral curvature. But neuromuscular may be something like a child that has CP, cerebral palsy, and other tightening of muscles can cause that. And here's a lateral curvature, is the spine here, and you're looking for what? Asymmetry at the shoulders, scapula, ribs, waistline, and you have them do what's called the Adams forward bending. So if you ask the person to bend downward like this, and you look front to back, side to side to look for asymmetry, they even have something called a scoliometer that you can use along the spine. It's a plumb line, like what a carpenter would use to see how even or uneven. You know we're probably going to do what? X-rays. X-rays will give you an idea of what type of curve do you have, what is the degree of curve. Further evaluation is needed by an orthopedist if there's any pain at all. Pain usually occurs in higher curvatures, like 75 degrees and beyond. When you get up around 75 degree of a curve, think about this. 90 degrees is a right angle. So 75 is not quite a right angle, right? By the time you start having higher degree angles, that spine is going to start doing what? Rotating on itself, and it's going to impinge upon cardiopulmonary structure. And that's where the pain is going to come in. But if you have no pain and it's less than a 25 degree curve, you just observe. And then if it's painful or greater than 25 degrees, you're going to refer. They usually do surgery around, let me just give you a hint. Surgery is usually in the thoracic region if the spine is about 40 degrees in the thoracic and 50 degrees in the lumbar region, just to kind of give you an idea. Here's your hip dysplasia, and we talked about it being displaced out of the acetabulum or subluxation. There's the Galeazzi sign that we talked about earlier in the Barlow and Ortolani's. Barlow's is good for the first 6 months, and Ortolani's is good for a first year. Remember, a young infant is very flexible. As they get older, their hip laxity changes. We also know that they may be present with a limp. Some kids that you don't pick up a real distinct Ortolani's, Barlow's maneuver in an infant, they may have a limp. They may have hip abduction that's decreased. We talked about leg length discrepancy. Pretty much x-rays and ultrasound is needed, and these kids do need to be referred over to orthopedics so they can determine whether or not it's significant enough to need some type of splinting with a Pavlik harness. Remember the word Pavlik? P-A-V-L-I-C-K. Do y'all remember that? Or surgery. Now here is an example, muscular dystrophy of a chronic progressive disorder. This is one that is the most common inherited neuromuscular disease, 1 in 3,500, typically 3 to 5 years. Remember earlier I said kids, little toddlers, should be able to get up and play with run with their partners and play. These are kids that are going to lag behind. They cannot keep up with their peers. This is the child that if you guys ask me to do the Gowers to get down on the ground, I'm going to do a Gowers maneuver. You know what that is? If you got me down on the floor and you asked me to stand up, I am going to have to do this because I'm old. I'm going to have to stand up because your pelvic girdle is weak, trying to get up. Little kids don't need to walk up there and straighten up themselves. They just jump up, right? Also, we know firm woody calves, large calves, because what is muscular dystrophy? They are missing a protein called dystrophin. That is the protein of their major muscles, and therefore if it's missing, they have a replacement of poorly degenerative, it's considered degenerative fibers that are not strong. They're also clumsy. They have a poor gait and posture. These are kids that are going to have proximal muscle strength that's decreased. They end up in a wheelchair, and they usually die from cardiopulmonary dysfunction. What happens is failure. What happens is, since it's progressive, remember we said it's progressive, so it's not like it's an ascending or descending condition. It's just that it attacks all the major extremity muscles. They become weak, and then eventually it's going to attack the muscle, the heart muscle, and so that's what they usually die from. What your goal is for managing them is, maintain, your labs and so forth. Your creatinine kinase is always a lab that would be important, and they usually ask a question on that. That's a pink pig, creatinine kinase, because it reflects what? Brain and muscle damage. And those will be elevated. Your EMG, ECG will also be helpful, and muscle biopsy could be done. But you know what? Pretty much you would, you could do that in gene analysis, but not everybody undergoes that kind of testing. Pretty much your management is to maintain and delay progression, maintain strength and mobility and delay progression of their symptomatic breakdown. In other words, they get very weak. So they're going to need what? OT, PT, and again, you got genetic testing. Now we're going to look at an acute condition called ankle sprain. Ankle sprain is a good example of result of sports injury, most common musculoskeletal injury. Usually a forced inversion, such as a lateral ankle, or eversion, medial ankle. So when you're walking down the road and you walk into one of those manhole things that aren't just even with the road, and your ankle kind of goes like that, that's what this is referring to. A lot of times on a test, they like to ask a question. You got a kid that's doing track and how they twisted their ankle, or maybe a kid on a football field. So you think they're going to ask something more involved about an injury. It's a sports injury, and they're really aiming to have you know that you understand how to manage this. It's graded. Now, grade 1, 2, and 3. Grade 1, is going to be what? It's a stretch. There's no tear, no joint instability. There's local tenderness, edema, ecchymosis, but you have full range of motion, and the child can do what? Maintain bearing weight. So when you have somebody comes into your office and you see them walk in to your office and they feel like they need an x-ray, you don't always have to jump to an x-ray. As a matter of fact, immediately, with a lot of times with the swelling, you occlude being able to observe a fracture. So you just want, and I always point that out to them. I see you walked in, looks like you're able to walk fine and so forth. So you try to make it real for them. Now, if you have a grade 2, partial incomplete tear, joint instability may be noted. Pain upon injury, they will report that to you, some ecchymosis, edema, significant pain while they're bearing their weight, and their range of motion is limited. It's not complete tear, but it's a partial tear. And of course, what's a 3? A complete tear. These are individuals that cannot do what? Bear weight, no range of motion, complete joint instability, edema along foot and ankle, profound ecchymosis that worsens. Actually, the ones that worsen, you've seen them beforehand. Like on the foot, you may see the bloody ecchymotic changes become very dependent and have a line of demarcation. You've seen that. Right? And oftentimes you'll have a fair amount of swelling on any of these that you may have to repeat an x-ray if you're doing an x-ray. May end up having to do an MRI to be able to get a determination. So the way you think about doing x-rays, the Ottawa Ankle Rule is if there's pain near the malleolus or bone tenderness about 6 centimeters from either side of the malleolus, so in other words, it's linearly along the foot itself, or the patient is thinking about, they report to you they just can't bear any weight, it's extremely painful, they reported not being able to even walk even 4 steps at the time of injury. They come in on crutches. That's the time to do an x-ray with the opportunity to repeat it. We know that all of these grades respond to RICE and NSAIDs. And that is what? RICE is rest, ice, 30 minutes on, 30 minutes off. And compression. Compression usually helps with edema, stabilizing the ankle. If they can wear an ACE bandage or a splint or put their foot back in the shoe, any of that will help support it. Elevate, and of course NSAIDs. And to always tell people to take NSAIDs with what? Food. Here's an elbow fracture, often associated with injuries resulting from outstretched arm falls. The thing I want you to note here is this fat pad sign. Usually there's no fracture visible on x-ray, but a lateral view will show the anterior and posterior fat pads. And if you can't see the fracture, the fat pad sign suggests the presence of an occult fracture. So they actually will note fat pads. So you want to make sure that you don't just overlook that there's probably an occult fracture, so you need to do a different view. And the view will be what? An oblique view. Because you got to get just a different perspective. In orthopedics, typically, a fracture clinic. We think about the nursemaid elbow. Nursemaid elbow is a common injury in young child, swinging, pulling. Doesn't that just get to you when you swing the kid and you think about their joints? Radial head subluxation. There's that term. There's a good way to look at it. What is subluxation? It's a dislocated joint. Remember we mentioned that it could be with hip dysplasia. Inability or refusal to use their affected arm. As a matter of fact, they have pain upon what's pronation, supination? Pronation, supination, like this. Sometimes they'll hold their hand like this, arm across the body with a thumb up. That's protecting it, feels better. Okay, pronation, supination. Just doing like that hurts. Significant swelling and bruising justifies an x-ray, of course. X-ray may be read as normal and usually not done. It depends upon this, and sometimes just good old supportive care. But you want to make sure that that joint has been protected. NSAIDs can be utilized for them. Remember, we can give ibuprofen as young as 6 months. So that was a kind of a unique chapter with some very unique pediatric considerations, and that's going to bring us to neuro.